very fortunate today to have Professor Sarah Pinder, who's internationally renowned breast pathologist from King's College London. She's going to be talking on, I think, papillary lesions of the breast. And I'm traveling, so I'm making the introduction short, and I'll let Sarah carry on her introduction herself. But not, but you know, I'm very very grateful for her time, and it's going to be a very useful session for you all. Lydia from Diagnostic will manage all the admissions in the meantime. So I'm sorry I can't be with you as much as usual. And so without further ado, before I'm interrupted by a further announcement, thank you very much, and I'll pass over to you, Sarah. Thank you.
Thank you very much indeed, Richard. Safe travel. Thank you for inviting me to come and give this talk. I will attempt to share my screen. And Lydia can tell me, is that there okay, Lydia?
Sorry, unmuting myself. That's good. We can see that.
See it all right.
Yeah.
Oh, I've got a Zoom work. It's a slightly niche topic, I feel, sort of today, on papillary lesions of the breast. And it's sort of based around a talk Richard has asked me to give for the Women's School for Pathological Society. So I don't know, you may be attending that as well. I'll dive straight in. I suggest that maybe you can put any questions, we'll do them at the end. Either put them in the chat or we can do it virtually. But if there's anything very burning, because I can't see the chat at the moment at the same time, so I don't think I can answer them as we could go along, which I apologize for. So papillary lesions of the breast. Let me do that. Papillary lesions of the breast in the WHO book mentions these 5 different entities under papillary tumours of the breast. Of course, things being as they are in pathology, it's always a little bit more complicated than that. And those 5 lesions with different combinations turn into more different and difficult lesions. I don't know how many of these you will see, but I'm going to touch on the intraductal papillomas, which may be single or multiple. They may have different sorts of epithelial hyperplasia, atypia, or even DCIS in them. Then you've got the sort of in situ cancers, papillary carcinoma in situ, and of course these may also have invasion, encapsulated papillary carcinoma, solid papillary carcinoma in situ, and then we've got the invasive entities, which I will touch on towards the end. If we go through those in some kind of order, for the intraductal or the mass lesions that aren't obviously invasive cancer, I think about them in 2 groups. And I'm sorry if this is a little bit idiosyncratic, but I think about them in the first group of lesions that have the underlying structure of a papilloma. So they have a surrounding myoepithelial layer because they're within a duct, and they have myoepithelium between the frons and the epithelium. So these are all things that basically are papillary papillomas, intraductal papillomas, but they may have something else superimposed on them. And the second group, the papillary carcinoma in situ and the encapsulated papillary carcinoma, the main biological difference, I guess, is that they don't have a myoepithelial layer between the fibrovascular frons and the epithelium in the middle. The papillary carcinoma in situ, as I'll show you, obviously does have a surrounding myoepithelial layer because it is in situ. Whereas the encapsulated papillary carcinoma, although it looks like a mass, we now know doesn't have a surrounding myoepithelial layer. So let's dive straight in. Here's a couple of shots of a papilloma here, a straightforward one. You can see you've got the surrounding duct space, you've got the papillary lesion in the middle. You can't see the connection on the wall between the two, but we've got the papillary bit in the middle with the fibrovascular frons and the overlying epithelium. In benign intraductal papillomas, and these are very simple ones, they quite often have this columnar epithelium over the top. The fibrovascular cores vary a little bit in thickness. Sometimes you'll see sclerosis, but they have a myoepithelial layer along here between the fibrovascular core and the overlying epithelium. Benign papilloma hopefully we'll all agree that's straightforward. On top of that papilloma, you may have an epithelial proliferation. That is usually relatively straightforward. Here we've got, you can see the fibrovascular core there with the papillary type columnar cuboidal epithelium over the top. But here we've got an epithelial proliferation. The cells in that proliferation are of mixed shape and mixed size. We've even got some irregular fenestrations here. So that's usual epithelial hyperplasia in a papilloma. If you are particularly worried and if you have access to it, you can do some immunohistochemistry. And just like you can see in usual hyperplasia, not in a papilloma, you can see that the epithelial proliferation in an atypical proliferation is uniform, suggesting clonality. So that's uniformly CK14, so basal cytokeratin negative. That's atypical. We suggest it's clonal, uniformly ER positive, whereas in usual epithelial hyperplasia and usual epithelial hyperplasia in a papilloma, you'll see a mixed proliferation with your basal cytokeratins. Here's CK56. ER can be a little bit more difficult in a papilloma because that columnar epithelium that you see lining the cords is uniformly luminal A ER positive, but CK56 is usually pretty helpful. So if we dive straight into some cases, and these are available to you, I think. I don't know if you've had a chance to see them yet, but they're available on the Winter School and on the PathSoc website. So you can look at them afterwards if you wish. It's a core biopsy. You can see that we've got rather fragmented bits of core here. We've got an edge of something there, which I've shown you on higher power here, which is the edge of a dilated duct. Normal cuboidal epithelium, bit of a columnar, a fibrous wall to it. But that's, so we've got an introductive something. And this, I think, is the portion of the lesion that's come out of that duct space. And on higher power, you can see that we've got fibrovascular cores in both these areas, not particularly thick, but also not particularly fine. And they've got blood vessels in them. We've got a patch of sclerosis there. But the epithelial lining is that typical columnar cuboidal type epithelium with an area here of apocrine change, which is always quite reassuring to see, because you very often see apocrine change in benign intraductal papillomas. No particular epithelial hyperplasia, maybe a little bit here, next to that area of sclerosis, which has got some little speckled microcalcification in. But that proliferation, like the one I showed you before, has a sort of mixed pattern. You've got these elongated, more oval cells mixed up with round cells. You've got some irregular sort of fenestrations or slits. So that's usual epithelial hyperplasia in a papilloma. So that we would classify that, because it's a papilloma in the UK, according to our core biopsy guidelines, as B3, but there's no atypia in it. What we would do then is we would actually do a vacuum assisted excision of that, because they can show heterogeneity. But the risk of there being anything associated with a papilloma without atypia is really low. It's about 5%. So in this sort of schematic that I showed you, here we're in the very top layer. We've got a papilloma, we've got a surrounding myepithelial layer, so it's intraductal. We've got a myepithelial layer, which I haven't showed you because we wouldn't have done the stains, between the cores and the epithelium. And we've got a little bit of usual epithelial hyperplasia. The next step, or the next case up from that, is another core biopsy. Again, obviously, of a papillary lesion here. We've got some fibrofatty tissue, and we've got these fragments, separate fragments of papilloma, papillary lesion. Here again, you can see the fibrovascular cores. That one's sort of slightly dilated here with a more obvious blood vessel in it. And we've got this overlying epithelium, which is a little bit different, a bit less straightforward than in the last one. We've got some of it being columnar, perhaps a bit multi-layered there, and a bit more closely packed. And then in some other areas, we've got these sort of smaller, round, more regular cells. And high power view of another area. You can see we've got the fibrovascular cores. It's obviously a papillary lesion. But we've got areas here where the cells are not so variable, the nuclei are not so variable in size and shape. We've got these little patches where we've got quite uniform, quite round, more evenly spaced cells. And in that instance, you may think about doing some immunohistochemistry, or you may just have enough confidence to say, well, that's a little bit atypical. But in general, we would say, we'll do some immunohistochemistry. We can see that there with P63, which is showing up the myoepithelial layer. You can see that there is a myoepithelial layer between the fibrovascular fronds and the overlying epithelium. And with CK5, which is really not the world's best myopithelial stain, but it does show that the epithelium in this particular papillary lesion is uniformly, well, largely uniformly negative. You've got a few little cells staining up in some areas. So that and the estrogen receptor, which again highlights these small, round, regular epithelial cell proliferation, suggests that this is not just usual epithelial hyperplasia. So we would call that as a B3, a papillary lesion, but with epithelial atypia. And in those instances, we would actually recommend that it was excised. The risk of having something either within the papilloma, i.e. this being DCIS in the papilloma, or having something else adjacent to it because of that epithelial atypia is more like 30%, so higher. So you do want to examine more of that tissue. So we're now in this ballpark. We've got a papilloma, and we know it's a papilloma because we've got the myoepithelial cells between the epithelium and the fibrovascular fronds. We've got a myoepithelial layer on the outside, so it is all intraductal, but we have got these little patches, which is all that we can see because we've got a core biopsy. So that's a papilloma with atypia. Part of the problem with these is that they're actually quite difficult to know what they mean and how to deal with them. And we use this very old paper from David Page from 1996 because there is really nothing better. We have a small cell atypical epithelial proliferation. Here's another case here with more obvious crib form pattern. And he described how if that's more than 3 millimeters in a papilloma, you should call it low-grade DCIS in a papilloma. And if it's less than or equal to 3 millimeters, then it's atypical hyperplasia, akin to atypical ductal hyperplasia in a papilloma. The numbers in this paper were quite small, and the outcome was not really very, very clear. In that it was really not, if you had atypia, it turned out to be this. If you had DCIS, it turned out to be that. But I think it's the best that we can do. So what we do when we have atypia in a papilloma, in an excision in particular, what you do is you measure the extent of that atypia. And if that's more than 3 millimeters, then you call it DCIS in a papilloma. Can be useful if you have access to it to do some immunostains in that setting, because if you do a myoepithelial stain, it does highlight the myoepithelial layer, but it also highlights the background epithelial proliferation. We go on a slight tangent now, if you'll bear with me, and this is case 8 of the cases that you can see access to. We've got another intraductal, or at least a papillary lesion here with a small nodule above. And that's the small nodule, which looks genuinely intraductal because you can see the epithelial layer there. And here's the main mass. This looks a little bit more complicated. There are areas here which clearly are the kind of glandular luminal type epithelium, but they look, in some areas, looks like a papilloma. But in other areas, it's a little bit more complicated. And even in these patches, perhaps there's a sort of population of cells in between the obvious glandular epithelial components. And in other areas, it's much more mixed, and it's quite hard to make out what is the epithelial component and the glands. But you have got the fibrovascular cores that you can see in the fibrovascular bands. So in that instance, I would do some immunohistochemistry, and what that shows is that all the myoepithelial markers that you do show that those prominent background cells are actually myoepithelial. So you've got this combination of negative glandular tubular structures and this surrounding prominent myoepithelial population with smooth muscle actin, with smooth muscle myosin heavy chain, and with P63. The other thing you can do if you don't have access to so many myoepithelial stains is you can do things like CK7 and CAM5.2, which will differentially stain epithelial and myoepithelial cells. And actually, they look rather beautiful, don't they? Particularly the CAM5.2. So you've got an epithelial proliferation, which looks quite bland, no atypia in it, no mitoses. And then you've got an underlying population, at least focally, not necessarily throughout, of this prominent myoepithelial layer. And you can see the luminal component with epithelial membrane antigen or with estrogen receptor, which we've got here. And you can see that there is a variation in estrogen receptor intensity in those cells. And it highlights that they all look quite regular and benign. So that's an adenomyoepithelioma. I'm sure you've seen these occasionally. They're quite rare. They're usually benign. And you have this combination of small epithelial spaces with the luminal cells, ductal luminal cells. And then you've got these surrounding myoepithelial cells, which are prominent, sometimes enlarged, sometimes they're spindle cell, sometimes they're clear cell. And they show the variation that you might sometimes see in myoepithelial cells. They usually present as palpable masses, often in older women, but there is a very wide age range. There are various types described, and I'm not quite sure there's a great deal of value in distinguishing that, other than mentally it helps you recognize some of the variants, like the adenosis variant. But you do get papillary variants, and they may be mixed. This particular case shows what is described, which is an intraductal papillary growth. Some areas there are features more of a classical papilloma, and sometimes there is much more obvious and prominent myoepithelial proliferation. Sometimes you can get a squamous or sebaceous differentiation, and in this one, if you do get a chance to look at it, there is a squamous area in the middle. They can be quite hard to classify. You can occasionally get malignant transformation in them, and that may be carcinoma arising from the luminal component, or it may be a metaplastic myoepithelial carcinoma arising from the myoepithelial portion. There's quite a nice paper, which I think I put the reference for. Yes, there's quite a nice paper from Imad Raka and a group of Ian and Cecily describing adenomyopitheliomas and how you might classify the different variants of progressive atypical adenomyopithelioma and malignant adenomyopithelioma, which I think may be worth reading if you haven't. So that's the papillary form of adenomyopithelioma. So not really a papilloma, but I've sneaked it in. If we go back to the more classical papillomas, here's our next case. Again, an obvious papillary fragments with fibrovascular cores. And then the epithelium over the top here is somewhat different to some of the other cases we've seen. We've got more crowded, more hyperchromatic, columnar-shaped epithelium overlying these very thin fibrovascular cores. And on H&E, you can't really make out a myoepithelial layer underlying those fibrovascular cores there. And if you do immunohistochemistry, you can see that there's no myoepithelial layer. So your H&E impression was right. That's with P63. So there is no myoepithelial layer between the columnar, multi-layered, slightly hyperchromatic epithelium and the fibrovascular cores, which are thin. CK5 is uniformly negative, ER is uniformly positive. Perhaps not quite so helpful. The bottom line with these is there or is there not a myoepithelial layer, and does it all fit? And that's papillary carcinoma in situ or encapsulated papillary carcinoma. We didn't have the edge, so we can't really tell what sort it is. Fortunately, in most instances, as I'll come on to, that doesn't matter. So that's a in situ malignancy, and you want a complete wide local excision with a margin. And this is case 4, which slightly cheekily is the actual excision of that last case. So this is the excision that she did have following her papillary carcinoma in situ diagnosis. And you can see we have got a well-defined mass here. There's not a particularly fibroblastic reaction on the outside. There is little patches of chronic inflammation that you can see there. And this really duplicates what we saw in the core biopsy, although perhaps I was being a bit disingenuous. Perhaps there is a bit of chronic inflammation and fibroplasia, fibroblastic reaction around it. But I say it shows you what we saw in the core biopsy. So we've got these very fine fibrovascular cores with an overlying columnar epithelium. Got little sort of apical tufts, really, fluffy pattern there. Not particularly atypical. You know, these cells are not markedly atypical. They've not got much pleomorphism. And unless you think about the diagnosis, you might just think, oh, that's a benign papilloma. But you've got fine fibrovascular fronds, and you've got no myopithelial layer that you can see. And you can confirm, sorry, I haven't done this must be smooth muscle myelin heavy chain, I think, because we've got staining up of the vascularity of the vascular buds in the fibroepithelial cells. And actually that is something to be aware of. If you've got dilated vascular spaces in the fibrovascular fronds and you're doing a smooth muscle actin or a smooth muscle myosin heavy chain, they will stain up endothelial cells. So sometimes you might mistakenly think that they're running along here under the epithelium, but they're not. But you've got dilated spaces and they can be quite closely opposed or next to them. So that is papillary carcinoma or encapsulated papillary carcinoma. And then you look at the edge of the lesion and you can see that we don't have a myopithelial layer around the edge of this entity either. So that suggests that it is an encapsulated papillary carcinoma, as does the little bit of fibrosis and chronic inflammation. Although in this particular case, that is not especially marked. So an encapsulated papillary carcinoma, I guess I'd probably call that low, intermediate grade. And so that can be treated akin to an in situ process, even though there's not a surrounding myopithelial layer. Basically, papillary carcinoma in situ is a term which I apply differently. You don't have to, this is what I do, apply differently to papillary DCIS. Which is actually not a term I tend to use. I tend to use the term DCIS in a papilloma when you've got the underlying structure of the papilloma and you've got DCIS in it, which is quite often cribriform, quite often low or intermediate grade. And it has a different architecture to what I would call papillary carcinoma in situ, which is this entity where you have the thin fibrovascular fronds and you have the overlying epithelium, sometimes more columnar, not particularly columnar in this case, but this is the entity where you have the fronds with no myopithelium around the outside. So it doesn't have the structure of a papilloma. It is semantic. You call it all papillary DCS, or whether you say one's DCS and a papilloma, one's papillary carcinoma in situ, it doesn't matter. But it just helps me to think about them as, because I think about them as different lesions architecturally. These things have thin fibrovascular fronds, whether they're in situ papillary carcinoma or encapsulated papillary carcinoma. They sometimes have this crowding and stratification, micropapillary tufting. Bottom line, I keep saying it, the absence of myopithelial cells. Papillary carcinoma in situ is intraductal, so you do have that surrounding myopithelial layer. Encapsulated papillary carcinoma doesn't have that, quite often has fibrosis, fibroplasia, and chronic inflammation. Again, it doesn't really matter in most instances, but I'll come on to when it might do. So this particular lesion is an encapsulated papillary carcinoma. Case 5 is where it might matter. So here we've got another obvious kind of mass lesion with a papillary structure on a low power. It looks very like the one I just showed you. We've got that sort of slight fibrosis and chronic inflammation around the outside. And we've got a papillary lesion in the middle with quite fine fibrovascular fronds. The way this is very different is if you look at the cytology. That last one was kind of small regular cells. This one around the fronds, you can see here better on the one on the right. We haven't got that much. These cells are large and atypical. If we compare the size of the nuclei, even the size of these big nucleoli, to red blood cells, you can see that they're certainly 3 times more the size of a red blood cell. So that's a high cytonuclear grade process. Smooth muscle actin, shows there's no myepithelial layer in the frons, no myepithelial layer on the outside. So this is another encapsulated papillary carcinoma, but it's high grade, and I think significantly it's estrogen receptor negative. You can see the positive internal control here in the lobular units there, where you've got nuclear staining, but in the lesion itself, you've got no ER positivity. Now, these lesions are a little bit being debated at the moment. You may be aware of this paper again from Emad Raka a few years ago now, which described this high-grade encapsulated papillary carcinoma and said it was under-recognized, which I think is true, but it's also rare. We might see 1 or 2 a year, whereas we'll see, I'm guessing now, but we might see 20 overall papillary carcinoma in situ or encapsulated papillary carcinoma. He says 3%. I think that's probably, again, a bit of a guess. But they described 12 in this paper, often hormone receptor negative, as this one is. They tend to be larger and more often have invasion. We'll come on to that in a minute. They had 10 patients, so it's really small numbers with follow-up data, but one of them developed recurrence and died of disease. So there is some suggestion that perhaps these high-grade variants, particularly those that are ER negative, may not behave in such a benign fashion and behave as in situ fashion. So there is a suggestion, and that's been passed on to the WHO book, that perhaps you should think about treating these as invasive disease. My own personal view is that I don't quite buy that, and that's partly because of the numbers of cases. I've seen high-grade papillary carcinomas that behave just like in situ disease. I've seen a couple over my many years, and I'm very old, that have had metastasis in their lymph nodes. So what we would do with these is we would the high-grade encapsulated, high-grade in situ papillary lesions, we would recommend a sentinel lymph node biopsy, whereas we wouldn't for normal, typical DCIS, or for papillary carcinoma in situ or encapsulated papillary carcinoma that weren't high grade. So we do manage these slightly differently, but we don't necessarily give them chemotherapy and endocrine therapy and all the other things you might do for an invasive disease. These are the pictures from Emad's paper, and I certainly buy this case as encapsulated. Well, actually, it almost looks in situ, but an encapsulated high-grade papillary lesion, and I'd certainly buy that case. Fine, no problem. I'd agree with that diagnosis. This case, I'm less sure I'd agree with the diagnosis, and I'm not talking behind his back. I've had this conversation with Emad, so he knows what I think. I mean, that to me just looks like masses. It's not a very good picture, but masses of kind of high-grade cells, maybe a little bit of fibrovascular cause. I suspect I would just call that high-grade, no special type invasive cancer. But I'd have to see the whole case to be certain of that. So you do want to be careful about making the diagnosis of high-grade encapsulated papillary carcinoma if your clinical teams are going to manage them like invasive cancer. Okay, we're getting there. There is another version of the in situ stroke encapsulated lesion, which is the solid papillary carcinoma in situ. Here you see well-rounded, circumscribed cells, and the fibrovascular cause, maybe you won't spot at first instance, you have to have a look at them. You may or may not have a myepithelial layer around the outside. So this is one that kind of breaks that rule of papillary carcinoma in situ versus encapsulated, because the solid papillary carcinoma, sometimes you don't have a myepithelial layer on the outside. They often show neuroendocrine differentiate, both on H&E and if you did do synaptophysin or chromogranin. You got the palisading around the cores. You may see signet ring features, and there may be extracellular mucin. And in that case, you want to be certain you haven't got a mucinous carcinoma there as well. They're uniformly strongly ER positive as well as neuroendocrine positive. And you sometimes get a form of neuroendocrine DCIS where you don't have the fibrovascular cause, but it may merge with solid carcinoma in situ. And if it's got a spindle cell pattern, the ER positivity can be uniform ER positivity can be very useful, because you might be mistakenly thinking it's due to epithelial hyperplasia. Here's the case that I put in for your examination. And you can see here we've got lots of little spaces that have got a solid proliferation in them. Some of them are expanded, and some have obviously got kind of small, subtle fibrovascular cores in that you can see better here. You've got that palisading that I mentioned, but it does look like an intraductal process. As I say, occasionally you can see streaming. This one's kind of fairly obvious, but sometimes you might mistakenly think, is that the streaming that you see in usual hyperplasia? But then you spot that elsewhere, you've got this small cell uniform, and these cells are what, just slightly bigger than a red blood cell form. And so this is solid papillary carcinoma in situ. Doesn't matter whether there's a myopithelial layer around the outside or not. If you've got these rounded clumps, you've got solid papillary carcinoma in situ. Okay, finally, let's go on to the invasive bunch. You can have solid papillary carcinoma in situ with invasion. And then you've got the patterns of the solid papillary carcinoma, so those rounded islands, but you may also have more obvious strands or clusters or invasive cells around the outside. It may be mucinous, slightly more often mucinous than you would expect by chance. It may be any sort. You may have tubular, you may have no special type ductal, or any other sort. This one is tricky. Sorry, this one is different to solid papillary carcinoma with invasion. I'll show you some pictures, which is very rare, and it's sort of small print in the WHO book, but there is an invasive solid papillary carcinoma. It is very rare, and I suspect I don't spot it as often as I should. Here you have nodules without some myopithelial on the outside, but slightly more ragged contours. So you don't have those rounded, well-defined edges. You have a sort of geographic jigsaw pattern, and you may have a desmoplastic stroma, and it may be infiltrating into fat. So let's see some pictures of those two things. So this is case 7, which I've given you in his example. And here you've got appearances like we had in that previous biopsy. You've got these rounded solid lumps or well-defined solid lumps, which are the solid papillary carcinoma in situ. But here there are obviously invasive cancer around the edges in several bits here, another bit here. So that's the solid papillary carcinoma in situ bit. You can see well-defined outlines and a myopithelial layer around the outside. I haven't got the immuno to show you, but I think you can see it even on H&E. You've got this sort of subtle fibrovascular cores, and you've got this round, evenly spaced cells. So that's solid papillary carcinoma in situ. But you've clearly got those bits as well, which are ductal no special type carcinoma. I don't think there's any particular diagnostic problem with that. You know, you've got these irregular shaped clumps. Haven't got so much fibroblastic stroma around these. And there's another clump here, little area. I'm not sure that's just retraction artifact or possible lymphovascular invasion, but you've got multiple little islands of invasive carcinoma associated with this solid papillary carcinoma. They are, depending on the red blood cell, probably twice and a bit the size. So I would call that 3 for tubules, 2 for pleomorphism, 1 for mitoses. So that's a grade 2 invasive carcinoma. Oh, good, that's what I said last time. So we've got solid papillary carcinoma in situ with invasive carcinoma of no special type, which is grade 2. You then have to think about how you measure the size of that. And there are some guidelines in the new updated Royal College of Pathologists document, which is online, because if you just have several clumps, it can be quite hard to know what you measure for the invasive tumour size. Sorry, I should have said that there is obviously the marker clip site. So that's where they've done a previous biopsy. And there's a macrophage layer around the outside. So in this particular instance, we've got invasive cancer here and down here and down here. So you'd give the whole thing as the invasive size. And this is the picture from that Royal College of Pathologists guidance, which sort of says how you measure the whole size, which is the DCS and the invasive size, and what you do if there are multiple islands of invasive tumour. And in this particular instance, I would measure the invasive size as the whole thing, because we've got lots of scattered islands. So that, like this one, is another example, solid papillary carcinoma in situ, but with invasive carcinoma, which is no special type. And so again, you measure that bit for the invasive size, and you measure the whole thing for the whole tumour size. Invasive solid papillary carcinoma, as I've already said, is rare. Excuse me. I'm not entirely sure that I have not missed this on occasions and just call it ductal no special type. And I don't think that matters enormously. But it's always nice to pigeonhole cases if you possibly can. So it's very rare. You've got irregular, and you can see here, irregular sort of ragged contours around the outside, but you have got this overall impression of a solid papillary lesion. So these clumps like that with fibrovascular cores in. You may have desmoplastic stroma, but not always. Sometimes fat infiltration, but not always. But you don't have a myopathy layer. And as I say, I think if you call this ductal no special type, it wouldn't matter. But it is, you can officially call it invasive solid papillary. And here's another one where you've got overall pattern, no myopathy layer. But these are more irregular outlines. So invasive solid papillary carcinoma. So a few more entities. How am I doing for time? Am I going on too long? No, we're doing all right. So invasive papillary carcinoma. So the names of all these things are the things that are a pain in the bum to remember. Invasive papillary carcinoma has been confusing because of nomenclature and people misusing different names. So if you look in the literature, some of the cases that they've called invasive papillary carcinoma, what they've actually called them are encapsulated papillary carcinomas invasion, and they've ended up calling those invasive papillary carcinoma, whereas actually what you should call those is encapsulated papillary carcinoma with no special type or mucinous or whatever that type of carcinoma is. Invasive papillary carcinoma is a type on its own. It is very rare. It's not the same as invasive micropapillary either. Sigh. Basically, you have these sort of mildly dilated spaces. They're not ducts, they haven't got a myopithelial layer on the outside, but what they do have is these papillary islands within them. Here's perhaps a better example. So you've got dilated spaces, no myopithelium around the outside, and these little micropapillary structures within them. And so that is invasive papillary carcinoma. It is very rare. It's quite nice if you see it. And if you do see it, it's actually relatively obvious usually. It's not the same as invasive micropapillary carcinoma, which is more common, particularly mixed with no special type. As a pure type, it's about 1 or 2% of cancers, but you very often see it, will see it's mixed with ductal no special type. Here you have these rounded empty spaces in which there are clusters of carcinoma cells, quite often nuclear grade 2 or nuclear grade 3, and they have this reverse polarity. So they'll have the nuclei more inside and the cytoplasm is more on the outside. And so they sometimes described as inside out tumours. The benefit or the reason to identify these is that they more often than by chance or more often than other cancers show lymphovascular invasion. So you need to look closely around the outside. And because of that, they are more often node positive. And lastly, the entity that I want to slightly cheat and mention to you is tall cell carcinoma with reversed polarity. The reason I'm including this under papillary is twofold. One is that the previous terms have all mentioned papillary in them. So they were first described by Vincenzo Eusebio, who called them breast tumor resembling the tall cell variant of papillary thyroid carcinoma. Other people have called them solid papillary breast carcinomas resembling the tall cell variant of papillary neoplasm. Tall cell variant of papillary breast carcinoma, solid papillary carcinoma with breast polarity. So they all had kind of papillary in the name, which has now disappeared and been lost. This is also very rare, but it's quite nice that if once you've seen it, you'll recognize it again. You get these nests, often in fibrous stroma. They may have a solid papillary pattern with fibrovascular cores. The cells, as you might suggest from the name, are tall and columnar with quite a lot of cytoplasm, and the nuclei are relatively bland, moderately sized, kind of oval, sometimes have nuclear grooves, sometimes have intranuclear cytoplasmic inclusions. The two things really that will, well, the one thing that will key you on to recognizing this is the reverse polarity. And then you'll see that the myopithelial cells are absent. They are mostly triple negative. So the oncologists, at least where I work, will go, oh, it's a triple negative breast cancer. And you have to go, no, 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 it's not that sort of triple negative breast cancer, because they usually are relatively indolent. Potentially local recurrence is a greater risk. And they do have a typical hotspot mutation that you can do, although I usually haven't bothered looking for it, because once you see it, it's imprinted in your mind. So that's not quite in focus. This is a really low power view. And as you can see, the reason I'm included it under papillary lesions is that it does look papillary. So you have these islands, and they look like they've got a papillary structure, and you go, oh, that's fine, that's multiple papillomas. And then the key is when you look at that, and then you go, bingo, this is small tall cell carcinoma with reverse polarity, because the reverse polarity is the thing that is very obvious, and once you see it, it's almost pathognomonic diagnostic. You can see that the nuclei are actually at the bottom of these cells, or bottom top of the cells, whereas the bit that's adjacent to the fibrostroma is the cytoplasm. So you've got this very much kind of layering of the epithelium of the nuclei towards the center of the lesion, and the cytoplasms around the outside. So that's why it's called reverse polarity. And if you do myopithelial layers, there is no myopithelial layer around the outside of these. The very first one of these I saw, I hadn't recognized it, and I said, I don't quite know what this is. It was sent to me as an opinion. I should have known what it was, but I hadn't seen them before. And this was many, many years ago. And I said, well, it looks like some papillary lesion, and it looks very bland, so I think it's okay. But perhaps you better take it out. So I got to the right answer, even though I didn't really know what it is. But actually, say tall cell carcinoma with reverse polarity. And I will stop there. I've only done 45 minutes, but I once was taught in a session that that's all that people can actually take in. So I think 45 minutes is quite enough, and I'll take some questions if you have any, or if you're still all awake and haven't gone to sleep yet.
Thanks very much, Sarah.